and rabies vaccine. And I think so. We have got the apt speaker, the person who has done many talks as such, and who's well versed in this field, as none other than Dr. Shija. And I think so she'll be able to clear all the doubts. So whoever is joined us on the platform today, especially the house surgeons or any other pediatrician or a medical officer as such, can definitely put forward your questions and clear your doubts, because this is a topic that will be every day. Whatever you said and done, how perfect you are, you always have a doubt lingering in your mind. So wishing the topic all the best and academic learning for each and every one of you. Thank you, Jay, AP, Jay, and welcome everybody for today's program as such. Over to Dr. Johnny.
Dr. Johnny will introduce Madam.
A hearty welcome to all of you to this tips program, sensitizing the house surgeons. Respected state president, my good friend, convener of this program, Dr. Gopi Mohan, the speaker for the day, Dr. Shija Sugnan Madam, Riyaz sir, and all dear pediatricians, medical officers, and also the house surgeons who have joined us today on this platform. Today we have one of the most sought after speakers of IAP Kerala as well as Central IAP, Dr. Shija Sugnan Madam. I am extremely privileged to introduce you our speaker for the day. She is the additional professor at SAT Government College, Trivandrum, Kerala. I would like to request all of you to mute your devices. She has held, she was the president of IAP Intensive Care Chapter, Kerala State Branch 2021 and 2022. She was a member of the State Medical Board, Health and Family Welfare Department, Kerala 2023. She was the instructor of Pediatric Acute Life Support, IAP ALS, TIPS, SOS, HOPE, POINT, MCAS. Her areas of interest are immunization, nutrition in critically ill, tropical infections, fluids, and electrolytes. She was awarded the prestigious M.O. John Memorial Award for the best publication in 2021 and 2022. The publications, she has authored the book on immunization, guidelines and application, second edition 2020. She has a lot of original research publications in national and international journals. She has contributed chapters in UG and PG textbooks, and she is the co-author of Kerala State Treatment Guidelines also. With these few words, let me introduce the speaker for the day, Dr. Shija Sugnan Madam. Over to you, Madam.
Thank you, sir, for those kind words. So good evening, everyone. First of all, I thank the IAP Kerala team led by Dr. Shimi Paulus. And we also have the president and Dr. Gopi Mohan. We have the president-elect, Dr. Riyasai, and Dr. Johnny to grace the occasion. So thank you for the opportunity. And I think I'll straight away go to the topic. So I would encourage students to please, whatever doubts you feel, please feel free to ask directly or put it in the chat box. My job exactly would be to it might not be possible to really cover the whole of all the FAQs, but I would like to instill upon you the thinking process, the whys behind hows. Because if you really know that why you are telling such an answer, then in any different situation, you will be able to answer that. So with that, let us start the class session today. So as you all know, the session is FAQs on tetanus and rabies vaccination. So what do I plan to cover? I would be covering tetanus vaccination, a bit of routine and catch-up vaccination. Then we will move on to TT in special circumstances, including newborn vaccination. And then from tetanus, we'll go to rabies. We'll briefly touch upon the pathophysiology and prophylaxis so that you do understand the rationale behind the recommendations that we would be discussing today. And then we would discuss schedule deviations, your route deviations, unusual exposures, and vaccination failures also. And of course, special situations in rabies vaccination also. So first, we have to understand that When we're talking about tetanus toxoid, we need to know that standalone tetanus toxoid is now not freely available. It is majorly replaced by TD vaccine, which contains a small amount of diphtheria toxoid, or the Tdap vaccine, which contains both diphtheria. Yes.
Do you have a slide?
Slide on the shared avunilla.
Shared.
Yeah, shit. Wait. Sorry, I think I forgot. Is it visible now?
Yes. Full screen aayilla.
Okay, I'll do it. Okay. So this is what we discussed, that we'll be talking about TT vaccination routine and catch-up. Then we'll talk about special circumstances, including newborn, rabies, pathophysiology and prophylaxis, schedule deviations, unusual exposures, vaccination failures, and of course, some other special situation in rabies vaccination. The first, we already said, standalone TT is now not freely available. What you have is a TD vaccine. That means, along with tetanus toxoid, you have a small antigen of diphtheria toxoid, or you have the Tdap vaccine, which has diphtheria as well as acellular pertussis. Both these vaccines are recommended for those above 7 years of age. While for those below 7 years of age, it's the DPT that is recommended. So the difference is, in DPT, the amount of antigen content of diphtheria as well as pertussis is more. TT remains the same. It's also available as combination vaccines with a varied number of names. Remember, all these combination vaccines and this capital letter DPT is recommended for those below 7 years. For those above 7 years, it is either TD or Tdap. So in this discussion, whenever we are talking about TT, remember, we are either talking about TD or a DPT. That means basically we are talking about a tetanus-containing vaccine. So among the vaccines, tetanus vaccine is definitely a king vaccine. Why do I say so? Because it's nearly 100% effective if given appropriately. And there are no contraindications for TT except anaphylaxis to a previous dose. Even if there is an anaphylaxis to a previous dose, what is recommended is desensitization of the vaccine rather than avoiding giving TT vaccine, because you should know that tetanus is a disease that cannot be eradicated because the spores are ubiquitous. It is an infection which can remain as a spore for years or decades. So that is why we are never aiming to, we cannot really take away the disease from the planet. The disease will always be there, but we can always prevent tetanus because the vaccine is almost 100% effective. So routine schedule, you all are aware. We give 3 primary doses in the form of DPT at 6, 10, and 14 weeks, followed by we have 4 boosters, that is at 1.5 years, 5 years, and at 10 years and 16 years, we give TD or Tdap, right? So we are having 7 childhood vaccinations, including adolescent, completed. So now, have you ever wondered, why is it that we give so many doses of TT? When you look at hepatitis B, another killed vaccine, you're giving at birth, then you're giving at 6, 10, 14, and then you say, forget about it. You don't have to bother about it. Unless you have an exposure, at that time, you can check your titers and decide. So a vaccine where you're not asking for boosters, that is hepatitis B. Whereas tetanus is a vaccine, you seem to be taking boosters throughout your lifetime. So have you wondered, why is it so? Is it so? It is so because tetanus is a disease of a short incubation period. On top of that, this vaccine is a toxoid. That means the antibodies are going to be produced when the toxin is going to be produced. So there may be a lag period. So for you to be protected against tetanus, you need to have pre-existing protective antibody levels. Whereas in hepatitis B, it's a disease of a long incubation period. The incubation period can be 6 weeks to 6 months. So your body has enough time to mount an antibody response and protect you before the disease manifests. So I hope you understood why so many doses of TT are recommended. So now let us see the first case. 14-year-old Lisa has met with an accident, but she had received a TT 2 months back. So anyone comes to you with a tetanus-prone injury and gives you a history that has taken a TT 1 month back, 2 months back, 6 months back, 1 year back, what would you do? Will you still give a TT? Or since it's an RTA and it is a tetanus-prone injury, you will decide to give both TT and TED-Glo. Or you would say, no, this child received TT 2 months back, so she doesn't require a TT. I'll just give a wound care. So which is scientifically correct? Now, for you to answer this question scientifically, you need to know that when you are giving a tetanus vaccine, that is tetanus-containing vaccine, initial doses are just sensitizing doses. They are not protective doses. So when you give a DPT at 6 weeks, don't expect the baby to have a protective antibody level at 10 weeks. No. The 6, 10, 14, the baby is getting sensitized to the tetanus toxoid. By the third dose of the tetanus toxoid, or in a bigger child, by the second dose after the tetanus toxoid, you will have a reasonable antibody titer. That means only after you have completed your primary series do you have an antibody level above the protective level. And this titer also over the years come down, isn't it? Whenever you have an infection, if you check for your antibody titer soon after the infection, the antibody titer would be high. If you check your titers, say 5 years, 10 years later, the antibody titers come down because the antibody producing plasma cells die. Then what is the point in taking these vaccines? If you have taken the vaccines, you create a bank balance of memory cells, which normally do not produce any antibodies. But such a person, if they receive an antibody without the lag period, immediately there is a far higher rise in antibody level. So we did understand that when you give the first dose, in fact, the first antibody will be produced only after 7 to 14 days. Even then, the antibody titer is not high. Only after someone has completed the primary series do they have a good antibody titer. Even then, over the years, when the titers come down, you need to boost it up with a booster. So, keeping that in mind, now you need to know that when someone takes a single dose of TB, he does not have a protection, no duration of protection. So, imagine it's an unimmunized person. He's having a tetanus-prone injury. So immediately you give a TT. This TT is not going to protect him from getting a tetanus with this injury, because this vaccine is going to produce an antibody only after 7 to 14 days. And during that time, he can still manifest the disease. Whereas if someone has taken at least 2 doses of TT 1 month apart, he has a protection close to 1 year. But what is ideal is everyone should be vaccinated with at least 3 doses of TT, with the third dose at least 6 months after the second dose, that is 0, 1, 6. So if you take 0, 1, 6, you get a protection for 3 to 5 years. And if you take 0, 1, 6 with a booster 1 year later, you get a protection for all kinds of wounds for 5 years and for minor wounds for 10 years. So what did you understand by this? Next time, when you get a person coming to you for a TT, you know, right? Patients don't come to you asking for opinion. Rather, they come to you telling, I want a TT, doctor. So when they come and ask you for a TT, please ask them, have you taken a TT ever before? If they say no, this is the first time they're taking a TT, then tell him, yes, you can take a TT now, but please come 1 month later for the second dose and 6 months later for the third dose. If you do that, you're protected for the next 3 years. And if you take a booster 1 year later, you're protected for more than 5 years. So try to get that 3 dose of TT for every person. So why is this 3 dose important? As you can see here, when you have a tetanus-prone injury, someone is with a road traffic accident. If he has taken less than 3 previous doses of TT, he is, as far as tetanus prophylaxis is considered, is as good as unimmunized. What does that mean? Such a patient would require both TT and tetanus immunoglobulin. So if you have received less than 3 previous doses of TT, you need to take both tetanus immunoglobulin and TT for prophylaxis. Whereas if you have taken more than 3 previous doses of TT, say you have taken your DPT 6, 10, 14 and 1.5 years, and now you're 20-year-old, after that you have not taken any TT, even then you require only a TT. You don't require a tetanus immunoglobulin. So anyone who has taken at least 3 doses of TT in the lifetime, whenever they get a tetanus-prone injury, All they require is a TT vaccine and not a tetanus immunoglobulin. And if someone who has received more than 3 previous doses of TT, with the last dose less than 5 years back, he does not require even a TT. I hope this slide is clear. If you have less than 3 doses of TT, for a tetanus-prone injury, you require both TT and tetanus immunoglobulin. If you have already received 3 doses of TT previously, whenever you are having a tetanus-prone injury, you never require a tetanus immunoglobulin. You only require a tetanus toxoid. Whether you require even a tetanus toxoid or not will depend upon when did you receive the last TT. If the last TT was 1 month back or 1 year back or 2 years back, you don't even require a TT. But if the last TT was more than 5 years back, then you require a TT. I hope that's clear. So now coming back to our child, 14-year-old child with a contaminated wound. So your decision will depend upon, did this child receive the TD at 10 years? So if this a child who has completed all her childhood immunizations, including the 10-year TD, she does not require a vaccine for this injury. If this is a person who received the last dose of tetanus in the form of DPT at 5 years and did not receive any vaccine after that, he requires only TD. He does not require a tetanus immunoglobulin because she has already received 5 doses of childhood tetanus toxoid. On the other hand, if the patient has received only 2 doses of TT or is unimmunized, will require both TD vaccine as well as tetanus immunoglobulin. So again, highlighting, those who have had 3 doses of TT do not require a tet globe, and those who have less than 3 doses of TT and have a tetanus-prone injury require a tet globe. So from that, an adolescent, let us now come to a small baby. So baby was discharged from the hospital, you must have heard, on the way, going home in an auto, met with an accident. So newborn baby, 8 days old or 10-day-old baby going home, has met with an accident. So road traffic accident, we all know, are tetanus-prone injuries. So does he require a TT? TT means you can say DPT also. But you need to know that for a baby, the DPT vaccination starts at 6 weeks. So that comes to the question. Why is it that we start DPT at 6 weeks of age? We start DPT at 6 weeks of age because a baby is able to make some amount of antibodies against the DPT only by 6 weeks of age. So there is no point in giving a TT or a DPT to a newborn baby before 6 weeks of age because he's not going to mount a response. Now, should we give tet globe? So that's a question we need to answer, or no action needed. So the answer is that tetanus prophylaxis in a young infant, that is those below 6 months of age, depends upon the maternal immunization status. If the mother is completely immunized, including the TT doses during the antenatal period, then this baby does not require a TT or tetanus immunoglobulin. On the other hand, if the mother is not vaccinated with 3 doses of TT or she has not taken the tetanus toxoid during pregnancy, that means the amount of antibodies the baby has received from the mother is meager or nil. In such a situation, the baby definitely requires a tetanus immunoglobulin. I hope that's clear. So young infants, the need for tetanus immunoglobulin depends upon the maternal immunization status. So now another situation. Adolescent was offered Tdap vaccine. You counseled him for Tdap, telling that diphtheria is there in the elderly or pertussis is coming back. And naturally, you know the TT costs 10 rupees and Tdap would cost more than 600 or 1,000 rupees. You've given it. And half an hour later, the father arrives with the vaccine cover and shows you that the date has already exceeded. That means it is an expired vaccine. Now what will you do? So I think that the main this thing, what you would really want is like this, right? Disappear from the scene. But unfortunately, we cannot disappear from the scene. We need to answer to the question. We need to find a solution for that. So what will you do if it is an expired vaccine? Yes, tell them, sorry, that something wrong, you have done something wrong. But tell them that it's unlikely to harm. An expired vaccine is unlikely to harm, but potency is expected to decline over time. So the vaccine needs to be repeated. So you can repeat the same day, or since it is a killed vaccine, you can repeat anytime later also. So you can repeat on the same day, or they can come to you 1 week or 2 weeks later and take the vaccine. Both are equally okay. I hope that's clear. So it's an expired vaccine. Don't worry, it doesn't harm, but the potency is not guaranteed. So from tetanus toxoid, we move on to the next one. That is rabies, right? Day in and out, it's something that we keep on hearing because there are more than 1.75 million dog bites happening every year. And unfortunately, more than 20,000 die due to rabies every year in India. And do you know that WHO goal is zero rabies, zero dog bite rabies by 2030? So this is what we're going to see. That is it possible to attain a zero rabies death by 2030? You should also know that Goa is the only state in India that is declared rabies free. So let us come to the first case. Anuj had a dog bite 2 months back. Now came to know that dog had died due to suspected rabies. So he had a bite 2 months back. And then he forgot about it. It was a small wound, so he cleaned the wound and left it. And now when he goes back to the place, someone said the dog died long back and it was due to rabies. So now what is your reaction? Do nothing. The patient is safe because it's already 2 months since he had the bite. Or you say, no, patient is not safe, but it is now too late to act. I cannot give the vaccine. Or you will go ahead and give the vaccine. Or you will go even one more step ahead and you will say, no, I'm going to give the vaccine as well as the rabies injection. Here again, if you need to answer this scientifically, you need to know what exactly happens in rabies. Now, you should know that when the dog bites, the rabies virus gets deposited in the local area of bite, right? The virus enters the tissue and multiplies. Remember, this virus can remain at the site of inoculation for days to weeks to months to years. It can remain there for a long time. Usually, classically, it remains there for 2 weeks, but it can remain there for months to weeks to years. And from the local tissue, after it multiplies, it finds the neuromuscular junction, and from the neuromuscular junction, it enters the nerve. And from the peripheral nerve, the virus then reaches the spinal cord. And when it reaches the spine, when it enters the peripheral nerve, you may feel a tingling sensation. So that may be some days or weeks back. And when it reaches the spinal cord, patients often complain of girdle pain, or whichever, lower limb-bane, it may be a hip pain, upper limb-bane may be a shoulder pain. And then the virus through the spinal cord, it will reach the brain. Once it reaches the brain, it multiplies and then it comes downwards and gets excreted in the saliva and the tears. Remember, this passage of virus from the site of inoculation to the brain, down to the your saliva and your eyes, it's at a rate of 2 to 4 centimeters per day. It's very important for you to understand that once the virus enters the nervous tissue, neither your vaccine nor your immunoglobulin is going to act. The vaccine and the immunoglobulin acts before the virus enters the nerve. So you want to neutralize the virus before it finds the nerve. Once it's inside the nerve, it is a safe haven. You cannot kill it. And it's also important for you to know that while this virus is traveling upwards through the spinal cord and towards the brain, the patient is not infective. It's only when the virus is excreted through the saliva, through the conjunctiva, then only the patient is infective. If you get a person and you're thinking that it is rabies, then you send the salivary sample or the corneal imprint for the rabies PCR. You may still not get it positive if it is in the initial time of the disease, because this virus gets excreted in a like periodically. It's not consistently, it is not excreted. So if your doubt is high, then at the time of death or near death, you definitely get the rabies in the saliva. So if in doubt, repeat rabies PCR to get that diagnosis confirmed. And now you understood that why when you have an injury in the face or the head, they say it is more dangerous. But you should know that virus can find the nerve wherever the bite happens, whether it is in your face, whether it is in your head, or whether it is in your leg. So every time you have a bite which has breached the skin, breached the dermis, it can find a nerve rapidly. Only thing is that your fingertips, your face, your scalp are highly innervated. Because it is highly innervated, the chance of a bite virus finding a nerve is more. That's all. It is not that you will not get a rabies if the bite is on the leg, and you will get a rabies if the bite is on the head. Either way, you can get rabies. So every time, and also remember, it is not the size of the wound that decides whether it is category 2 or category 3. It is the depth of the wound that decides it is category 3. If you find a blood at the site of bite, it is category 3. So that has to be very, very clear. What is category 2? Category 2 is just nibbling. Means that is you don't have, somebody has, the dog has come or the cat has come and nibbled your skin, but there is no bleeding. If the bleeding happens, even if it's a scratch, if the blood is there, it becomes category 3. So it's important to know. And also important to know, now you understood that whenever someone is coming from multiple bites, you have to meticulously sit with the child or the adult and find each and every wound, because we need to inoculate each and every wound with rabies immunoglobulin, because the smallest of the wound can allow the virus reach the nerve, and once in the nerve, your vaccines and immunoglobulin is not going to act. So how do you protect yourself with such a deadly disease, one of the rare vaccine preventable diseases which is 100% fatal? We have a 3-pronged attack. So number 1 is local wound care. Number 2, rabies immunoglobulin. And number 3, anti-rabies vaccination. All these 3 prongs are important. The local wound care, never take it lightly. Whether the patient comes to you or at home, immediately wash the site with soap and running water for at least 15 minutes. Because this washing with 15 minutes itself is going to remove more than 90% of the virus from the site of the bite. And after you have washed thoroughly with soap and water, disinfect the wound with a virucidal agent, which may be your surgical spirit or an iodine, because this would kill even more viruses which are left behind in the wound. So this is a very, very important step. Never ever neglect this. This has to be done whether the bite is on the face or the scalp or the leg. And once that is done, then if it is a class 3 wound, inoculate immunoglobulin. Whether it is human immunoglobulin or your equine immunoglobulin or the newer monoclonal antibodies, because this immunoglobulin will immediately go and kill the virus, what is left behind. So washing took away majority, adding the virucidal agent, again removed whatever was there, and whatever little was left will be handled by the antibody, pre-existing antibody, which you're going to give as immunoglobulin, which is going to neutralize the virus at the site of inoculation. So remember, when you give immunoglobulin, it is important that you are inoculating at the site. Giving the rest of the immunoglobulin at the site, away from the site of bite, is not of much use. In fact, WHO is no more recommending even that. So the main thing is, wherever the bite has happened, we have to sit with the patient and infiltrate the wound with the immunoglobulin. So if all this is happening, then what is the vaccine needed? You're washing and removing the virus, you're adding a virucidal agent to remove what is left, and then you've given an immunoglobulin to neutralize the vaccine virus, the rabies virus which was there. If all this is going to protect, then what is the role of vaccine? So we need to understand that when you are giving a vaccine, as I already said in the first slide, immediately you don't get an antibody titer. When the vaccine is administered, it is taken by the dendritic cells, it is taken to the regional lymph nodes where initially IgM antibodies are produced, and then the B cells migrate with the help of T cells to the germinal center, cause a germinal center reaction, and produce large amount of IgG antibodies. These antibody IgG producing plasma cells die off after some time, but those plasma cells which go and hide in the bone marrow niches persist for long and provide you with low levels of antibody titers. Now, this slide is important for you to understand that the moment you give a vaccine, you don't get a protection. There is some time for the protection to happen. We also understood that when you give a vaccine, after some time, you get a very good antibody response. But we also realize that these antibody producing cells die off, but the memory cells are left behind to help you. So that is the role of vaccine. That is, when you give a vaccine, the antibody starts producing by the 7th day of the vaccine. And you can see here that the vaccine antibody titers are very, very high. And in order to protect the first 7 days, that is when the vaccine is not yet started producing the antibody, you are giving the immunoglobulin. So the immunoglobulin acts at the site of inoculation for the first 2 weeks. After 2 weeks, there is no immunoglobulin. If some virus is left behind, that will be tackled only by the vaccine antibody. So that is the importance of giving the vaccine. As I already said, virus can persist at the site of inoculation for days to months to year. So after 2 weeks, if you want something to neutralize the virus which is hiding at the site of inoculation, that is going to be your vaccine. So it is important that we give vaccine also. Even though vaccine protection starts later, vaccine gives you a higher protection. And that is also the reason that after 7 days of starting a vaccination, rabies immunoglobulin should not be given. So imagine you have a class 3 bite. First day you came, you forgot to give a rabies immunoglobulin. The patient only received the vaccine. When he comes for the second dose on day 3, you can give the rabies immunoglobulin. But after the third dose on day 7, he's coming on day 10 or day 14 and telling that it is a class 3 wound, you cannot give rabies immunoglobulin. RIG can be given only up to 7 days of starting the vaccination. I hope it is clear. It is not 7 days from the bite. It is 7 days from the vaccine, because by the 7th day, the vaccine would have produced a higher antibody titer than the antibody that you are going to inoculate at the site. So coming back to our child, so what should you do? Our patient is not safe because the incubation period can be few days to even 6 years. So patient is unsafe. And our injury is class 3. So however long the interval since the onset is, our patient requires both the anti-rabies vaccine and rabies immunoglobulin, because it's a class 3. I hope that is clear. So we again repeat, the incubation period is classically 1 to 3 months, but it can be as short as 4 days and as long as 6 years. So however the late the patient comes, start the post-exposure prophylaxis according to the class of the wound. If it is class 2, give only the vaccine. If it is class 3, give both the vaccine as well as the immunoglobulin. So now coming to the next child. This was one of our children, a child who came to us. She, in fact, a 3-year-old child, had a very tiny bite, unprovoked bite it was, a 0.5 centimeter bite on the shin. Still remember the child so well. And she received the anti-rabies vaccine intradermally from day 1 itself. On day 25, she presented to us with ataxia. Initially, we thought maybe vaccine-induced demyelination and all. But within 24 hours, she worsened and was intubated. And post-intubation, since the GCS was very bad, we did a CSF study as well as we sent corneal imprint. Both came positive for rabies. So this was a confirmed case of rabies in a child who had received an anti-rabies vaccination. So where did we go wrong? This is something that is not unusual for us to see. Like we in the media, we do come across so many instances where patients have developed rabies in spite of getting vaccine. Personally, I have seen at least 8 cases of rabies, but all the 8 cases that I had seen were either unimmunized or inappropriately vaccinated. That means class 3 wound receiving no rabies immunoglobulin. But in the paper, you also come across patients who have received both vaccine and immunoglobulin and still presenting to you with disease. Now, what could be the reason? Initially, people pointed at the quality of the vaccine. They said that maybe there is something wrong with the government supply of the vaccine, and that is the reason why vaccination failure is happening. We need to know that anti-rabies vaccine samples from Kerala have passed the quality test, so there is nothing wrong with the quality of the vaccine available. Then people said that if quality is okay, then it must be something the way we are storing the vaccine. That is the reason the vaccine failure is happening. We need to know that rabies vaccine is a relatively thermostable vaccine, so it is unlikely that a temperature instability is acting on the efficacy of the vaccine. You would have also noticed that we never have had a clustering of vaccine failure. That means it has never been happened that a dog has bitten 4 or 5 people and out of all the 4 died because of vaccination failure. It has never happened. So again, pointing to the fact that it is not due to the thermolability or due to the vaccine quality. Then the doubt came, is it that the way the vaccine was given? If the vaccine is not at the problem, the administrator is at the problem. So what is an invalid dose? It's very, very important for you to understand that if you give a rabies vaccine intramuscularly in the gluteal region, it is invalid. No vaccines are given in the gluteal region. So rabies vaccine, hepatitis B vaccines especially are invalid and it needs to be repeated because these are killed vaccines. They need to be taken up by the dendritic cells to be taken to the regional lymph nodes. In the subcutaneous plane, the dendritic cells are very less in number. That is why rabies vaccine should never be given in the gluteal region, because in the gluteal region, the vaccine becoming subcutaneous is high. So if it is given in the gluteal region, it is invalid. Please repeat it in the deltoid, or if it's a small child, anterolateral part of the mid-thigh is also okay. Similarly, as a house surgeon, you might be working in the preventive lab, preventive clinic, and you may be required to give an intradermal dose. And we know that it is not always possible to really create that V, isn't it? Many times when we give, we might not get that V, that puree orange does not appear. If you don't get a V, remember that vaccine dose is invalid. So what is the rationale? Imagine when you're giving a vaccine IM, you're giving 0.5 ml. When the same vaccine you're giving intradermal, you're giving only 0.1 ml. So how is that both the vaccines are equivalent? That is because in the intradermal plane, there are a lot of dendritic cells. And from the intradermal plane, these vaccine antigens are directly taken to your lymph nodes through the lymphatics. So the antibody produced following an intradermal dose is very high. So that is the reason such a small dose is given in the intradermal plane. But it is important that it goes in the intradermal plane. So when you are vaccinating, if you don't get a V, do not hesitate. Poke the child then and there, another dose should be given, which should elicit a wheel. So only if the wheel has come can you take it as a valid dose. If the wheel is not there, do not hesitate to repeat. So this is what I said, that the wheel should be there. So then the question came, is the vaccine failures happening because we have moved to the intradermal regimen? Is the intramuscular regimen superior to the intradermal regimen? You should know that intradermal regimen is not something new. It has been there since 1992. So before probably many of you were born. The first intradermal anti-rabies clinic of North India was started in 2008 in Shimla. And when the intradermal dose was introduced, the number of people seeking vaccination increased by 3.2 times. That means the more people got vaccinated, more disease could be prevented. So intradermal vaccination is a success story. But still the question comes, who is the king? Is it the intradermal or the intramuscular? The answer is, have no doubt, intradermal is definitely the king. As you can see here, the antibody titers following an intradermal vaccination initially at least is much higher than the intramuscular plane, due to the same reason I said, because there are a lot of dendritic cells. And remember, when you're giving an intradermal vaccine, you're giving 2 doses, you're giving it 2 sites. So there are more dendritic cells coming and taking away the antigen to the regional lymph nodes. So intradermal plane is no way inferior to intramuscular plane. And that is what the WHO says, that have efficacy equivalent to or higher than the same vaccine when administered in the intramuscular route. So route is also not at correct. So then why does the vaccine failure happen? If all this is not happening, then we need to know that in a rare situation, the virus may directly get inoculated into the nerve. The dog is biting and right on top of the nerve, and the virus is directly getting inoculated into the nerve, then the vaccine failure can happen. And multiple bites, when it happens, you may miss small bites, and through those small bites, the virus may find the nerve. As I already said, once inside the nerve, the antibodies and the vaccine is not of use. So these are the rare reasons why rarely you get a post-exposure failure. And in Kerala, why you are hearing more, we used to hear more cases, that is because the denominator has also gone up, because we are giving more than 5 lakh anti-rabies vaccines per year. So when such a huge denominator happens, naturally, the incidence of failure would also increase. But does that mean we accept this failure? Is there any way we can prevent even this? The WHO said that it is 0 by 2030. Here, can you mute it? Okay. So multiple bites, multiple bites, that we always said that. So
Dr. Sheila, muted.
okay. So I think now I'm audible. So, so what I was telling is that when you have a post-exposure failure, we said the reason. But does that mean that we just agree, yes, so rarely the failure can happen, so it is okay? No. Can we do anything to prevent even this failure? Yes, we can do. And what is that? That is by vaccinating the pets and stray dogs. And number 2, definitely providing pre-exposure prophylaxis. Till date, there has been no vaccination failure in a person who has received a pre-exposure prophylaxis. So a pre-exposure prophylaxis is definitely warranted. How do you take a pre-exposure prophylaxis? You can take either IM or ID. You can take 1 dose on 0, 7, and 28. WHO now says that even 3 doses is not mandatory. Even if you take 2 doses, that is enough. But the national guideline says that it's better to take 3 doses. That is 0, 7, and 28. So what is the advantage of taking a pre-exposure prophylaxis? If you take a pre-exposure prophylaxis, if you're having a bite, the next 3 months, you don't need to take any vaccine or immunoglobulin. This is applicable for post-exposure prophylaxis also. If someone has taken an anti-rabies vaccine and 1 month later again has a bite, the patient does not require a vaccine if he has completed the post-exposure prophylaxis, because for 3 months he is protected. And even after 3 months, if he has a re-exposure any time in his life, the WHO recommends that he needs to take only 2 doses, that is 0 and 3. There are no vaccination failures reported in those with previous pre or post-exposure prophylaxis. And anyone who has taken a pre-exposure prophylaxis do not require a rabies immunoglobulin even for a class 3 bite. So that is an advantage. So imagine if you've taken a pre-exposure prophylaxis, nobody is going to poke you at the site of bite. Nobody, if someone misses a small bite or a big bite in your head or scalp or somewhere hidden, also you are not going to be harmed, because someone who has taken a pre-exposure prophylaxis does not require a rabies immunoglobulin. Now the question is, why is it that you don't require a rabies immunoglobulin because you've taken a pre-exposure prophylaxis? The reason is, if you've taken a pre-exposure prophylaxis, in your body, you have a lot of memory cells. What are the memory cells doing? They're simply moving around like this, doing nothing. But the moment a booster is given, immediately the memory cell will recognize the antigen and convert itself into a plasma cell and start producing a lot of antibodies. So this is exactly what you mean by pre-exposure prophylaxis. By pre-exposure prophylaxis, you are creating an army of memory cells to help you in future. To help you in future, you have to take a vaccine, but the moment a vaccine is taken, immediately the antibody titers go up. Remember, this is the same reason we said for tetanus. If someone has taken 3 doses of tetanus, he has enough army of memory cells in the body. Such a person never requires a tetanus immunoglobulin. Similarly, anyone who has received at least 3 doses of rabies vaccine in his lifetime, which is appropriately spaced, he has enough memory cells. Just by taking a booster, he will create a lot of antibodies. And those who have received a rabies immunoglobulin in the lifetime, remember, it is once in a lifetime thing. You are not going to take an RIG again and again. Okay. I hope that is clear. Now comes a question. It is not uncommon that someone has gone to the private hospital, started the vaccination on the IM schedule, and then comes to the government sector and says, I don't have money, I don't want to continue IM, can you please continue my vaccination schedule here? It happens the other way around also. You might have started from the government sector and then comes to the private sector. What do you do? Can you do this mix and match? That is regarding the vaccine brands. Can you mix and match? The route, ID, and IM, can you mix and match? What does the guideline say? The guideline says that as far as possible, do not shift from intramuscular to intradermal or vice versa. If possible, do not shift between brands also. It is always better to take the same route and the same vaccine. But if it is unavoidable, continue post-exposure prophylaxis as per the new vaccine and schedule. There is no need to restart. So under no circumstances are you going to restart. You're just going to continue the schedule in the new route and dose. But as far as possible, the shifting should be avoided. So now, this is also not uncommon. You have advised everything, you've written the date and all, but the patient will come when they feel like. They have taken the first dose of vaccine, then they may land up on day 7, they may land up on day 10, they may land up after 1 month. What do you do? Do you need to start from the beginning or do you need to start from where stopped? Remember, as far as immunology is considered, every vaccine that you receive, you have a bank balance, you have an account for that. Okay, your body remembers that. So you never need to restart the vaccination schedule. You just need to start from where stopped. So remember, if a patient has taken the day 0 vaccine, he's coming on day 10. So consider the day 10 as the day 3. Give the day 3 vaccine on that day. Ask him to come after 4 days to take the day 7 vaccine. So you just shift the schedule ahead. You are not going to start from where start. So if any doses are delayed, vaccination should be resumed and not restarted. Second visit, we already said that. Now, what about this? Drinking a rabbit cow's milk. This is also not uncommon because what happens is that you have someone has a dog has bitten a cow and the cow's milk, the owner keeps on giving the milk. And when the cow dies, only then you realize that, okay, then the community comes to know that the cow was having rabies. So now what do? The whole people around that cow, the whole batch of people who are having the cow's milk would come to the hospital asking for the vaccine. So should you give a vaccine? You need to know that. Cow's milk exposure, no prophylaxis is needed. Rabies is not an orophycal route transmission disease, so no prophylaxis is needed. No report of rabies being transmitted by drinking milk. Don't encourage drinking milk, but anti-rabies vaccination is not recommended. I would say when such a patient comes, use that opportunity to provide him with a pre-exposure prophylaxis. Another villain, the rat bites. The rats are there everywhere. And this is also very common that you have a rat bite. Unfortunately, even your hospitals, your railway stations, everywhere you can have this. So now the question is, should you take an anti-rabies vaccination or not? The answer is, number 1, watch the site. Number 2, get the TT vaccine if the patient is due for a TT vaccine. Number 3, you need to know that rats, squirrels, rabbits do develop rabies. It is not that they don't get rabies. They do get rabies. But the fact is that these small creatures, once they get rabies, it is if you imagine a rat is bitten by a cat, it is unlikely to survive. So it is unlikely to transmit. That is the reason why we say that anti-rabies vaccination is not needed when you have a bite from a house mouse. The small rats in the house or those when they bite, you don't require an anti-rabies vaccine because it normally does not transmit. But in our hospital, we had a case of rabies, proven case of rabies following a squirrel bite. Your textbooks will say squirrels, you are not going to get a rabies vaccine, you're not going to get rabies. But the behavior of the animal is important. Imagine you're simply sitting outside and the squirrel is coming, biting and going. That should not happen, right? Squirrel usually runs away when you go near it. Instead, it is coming to you and biting. That means definitely something wrong with it. In such a situation, definitely you need an anti-rabies vaccination. So, and also when you have bandicoots, wild rats, the huge ones that you see in many marketplaces, then if that is biting, definitely you require an anti-rabies vaccination. Again, I would say such a situation, use it for a pre-exposure prophylaxis. Another situation is people will come and say, eagle came and has an injury on the scalp or a hand, or vulture. Vulture, we don't see it here, but in dry areas, in deserts and all, you can have a look. With people traveling around, you can come across so many different, and sometimes you have wild boar injuries. So remember, all wild animals are considered, any exposure is considered as rabies, whereas birds don't transmit rabies. So you do know that bat is not considered as a bird, it's a mammal. All other birds, rest assured, they do not transmit rabies. So what about large class 3 bites? Should it be sutured? So now you sometimes see a tendency that people are more bothered about the cosmetic appearance. So the moment a face bite is happening, the lips are hanging loose. It's so grotesque to watch. And so you feel that, okay, I'll go ahead and suture it. But remember that in a rabies, in a rabbit bite, when you're suturing, you are creating another path for the virus to find a nerve. So that is the important thing. That is the reason why we say don't suture, because you are creating a trauma. You're creating a way for the virus to reach a nerve. So what should you do? Avoid if possible. If possible, do a secondary suture. But always it is not possible. So in that situation, what should you do? First, thoroughly wash the area. Then, as we already said, apply alcohol or povidone iodine. Then infiltrate rabies immunoglobulin, then wait for a few hours, and then use suture. And that too with minimum number of bites, use sutures. You can do a secondary suture later, because rabies is fatal. That needs to be remembered. Now, throughout this, we said about so many conditions, but we did not touch about immunocompromised. So what about patients who are taking steroids? What about patients who are taking biologicals? So for them also, is it the same that we are going to practice? No. This is a totally different subset of patients, because in an immunocompromised, you cannot guarantee that the vaccine is producing enough antibodies. You cannot guarantee that they have created an army of memory cells, because immunocompromised, the antibody producing cells and the T cells both are suppressed. So your memory cells will also be less in number or negligible. So in these precious patients, both category 2 and category 3 require rabies immunoglobulin. And all re-exposures, you have to use a complete schedule. You're not going to say that this patient had received rabies immunoglobulin previously, so he doesn't require now. You're not going to say that he had a vaccination last year, so he does not require now. All exposure, just think that this is a new patient. For an immunocompromised, for class 2 and class 3, they require rabies immunoglobulin, and they also require a complete schedule. And check titers 7 to 14 days after the first vaccine dose. There are guidelines which mention that check titers 1 month after completion of dose. But if you check titers after 7 to 14 days since the day of starting the vaccination, you can offer them extra doses if the antibody response is not happening. So with that, all this, where did we miss out on the 10-day interval, isn't it? Many people say that you have a bite, observe the animal for 10 days. If the animal is okay, you don't have to worry. So from where did we get this 10-day? Do you know the rationale for this 10-day? The 10-day rationale came because a symptomatic infective dog is unlikely to survive beyond 10 days. So if you were bitten by a dog and the dog had rabies virus in its saliva, then the dog will die before the 10th day is completed, because most of the median survival after the rabies virus appears in the saliva is 4 days. And salivary excretion prior to 3 days before the onset of illness is extremely rare. So that is the reason we say that if an animal is alive for 10 days after the bite, it is unlikely to have had the rabies virus during the time of bite. But does that mean we will wait for 10 days? Absolutely not, because Vakt and virus waits for none, wait for none. Do not observe, start the post-exposure prophylaxis immediately. What if the bite was a rabbit bite? What if the virus has already entered your nerve? There is no point in starting the anti-rabies vaccination after the 10th day when the virus has already reached the nerve. So never ever wait. Offer the post-exposure prophylaxis in a timely manner. So what did we learn? We learned that we need to educate public and doctors on strategies of rabies prevention. We need to provide proper post-exposure prophylaxis. It is highly effective. There are only very, very rare instances of vaccine failure. Even those vaccine failures can be eliminated if we provide pre-exposure prophylaxis to high risk and vaccinate stray dogs and pets. So, if our mind can conceive, our heart can believe it, and we can achieve it. So, it is possible to achieve zero rabies death by 30. Thank you.
Thank you, madam. It was a very excellent talk, and you have left no corner untouched of rabies and tetanus vaccine. It is very important and helpful for the house surgeons and the doctors who attend these cases on a daily basis. I request Riyaz to say a few words. Riyaz?
Okay.
Riyaz, are you there?
So as always, yes. Can you hear
Yeah.
me?
Yeah, our minimum guarantee.
Yeah.
Maximum guarantee.
Yes. As always, Shija explained everything well. Regarding this injection technique, is there something they have to look failure? You can repeat that, but to make sure that it goes intradermal, can we advise the children how can we do it? Something like that.
Yeah, the house surgeon should be trained actually, even interderm. So it's difficult to give interderm than I guess. Madam, we have few questions there. Madam, can you hear me?
I think in between the connection is going. Yes, I can hear you.
Yeah, one question is this 3 doses what you talked about of TD, is it irrespective of TD given in national immunization?
No. It is including the TD given in the national schedule. So anyone who has taken 3 doses of tetanus containing vaccine does not require a tetanus immunoglobulin. So if the patient has received 3 doses of DPT and is now coming at 10 years of age, has not taken any vaccine, he requires just a TD. He does not require a tetanus immunoglobulin.
One more question I think to solve. In case of Anu case scenario, does the observation of dog for 10 to 14 days apply?
I think, Nivedita, we did cover that, right? Don't
Yeah,
wait.
we did cover that. Yeah, we did cover that. Does all bites with bleed be termed as class 3? That also we can cover.
No, I think that is very, very important for you to understand that this minimal bleeding is class 3. It's very, very important to know. It's very, very important to know because the cases that I said, I've seen 8 cases of rabies and all these cases were minor injuries. And because of the minor injuries, the rabies immunoglobulin was denied. So that is very, very important because you are not the major injuries. Everyone gives the rabies immunoglobulin. They are not the ones who land up with rabies vaccination failures. The rabies vaccination failures usually is inappropriate post-exposure prophylaxis. Usually it is because rabies immunoglobulin is not given for small wounds. So if there is a bleeding happening, please give rabies immunoglobulin. It is needed.
We have covered, ma'am, duration of protection of ARV, when to give repeat ARV for the second time.
So this, according to the WHO, earlier we used to say 3 years, 5 years and all. But now the WHO says that once you have taken 3 doses of appropriately placed anti-rabies vaccine or you have completed a post-exposure prophylaxis, you are in fact protected for life. So if you are not immunosuppressed, every time you have a re-exposure, you only need to take 2 doses of anti-rabies vaccine. That is 0 and 3. You don't have to repeat the whole series and you don't require a rabies immunoglobulin. A particular series of ARV gives you protection only for 3 months. So if you've completed a pre or post-exposure prophylaxis, the duration of protection is only 3 months. Beyond 3 months, you need to take the vaccine, but only 2 doses, 0 and 3.
there is an oral lesions in human mouth with abscess ulcer or minor abrasion.
Okay, the
That's
answer.
rabies.
Okay, that's a very interesting question. Thought process, I would say. But basically, we need to know that rabies virus is not excreted in the breast milk. So the chance of it infecting is not there. In such a doubt, if you have, go ahead and give an anti-rabies vaccine, but it is no cases have been reported till now.
They were concerned whether it is an abscess ulcer or minor abrasion between brushing with its breast. But we had already covered in that slide. Okay, the rabies bred to infected cows milk also we have covered. If the dog is, one more thing is, does this expiry of vaccine decreasing its potency cover only rabies or other vaccines?
What? No, which question did you ask? What about vaccine?
That was in a YouTube. That does this expiry of the vaccine leading to decrease in potency only on is applicable to all other vaccines?
Every vaccine. We're not talking about a Tdap or we're not talking about a rabies vaccine. Whenever we have a situation where you have administered a vaccine beyond the date of expiry, the potency cannot be guaranteed and it needs to be repeated.
Okay. If the dog is domesticated and vaccinated, can we wait for 7 days to give it RI?
Okay, that is also one question. Say in the Western world, they do that. But as far as the national guidelines in India is considered, it is not recommended because the reason is there are a set of criteria which we need to fulfill to say that you're protected from a pet dog. That means the dog has to be at least 1 year of age. The dog has received both the doses of rabies vaccine, and then and you have given the appropriate vaccine, a good quality vaccine. All this cannot be completely ensured. So even if you have a pets at home, the pets need to be vaccinated and you need to receive your pre-exposure prophylaxis. That is always advised.
If immunoglobulin is given in the past, if again class 3 fight, it's only idea needed.
I think Dr. Gopi cut when you're speaking, no, full clear right.
Okay, madam. Now, clear now?
Clear now, I can hear.
And if immunoglobulin is given in the past, when the child comes again or anyone comes to class 3 fight, it is only idea indicated.
I didn't get the question.
The question is, I think, so if the immunoglobulin is been given in the past, and if again a class 3 bite, should only IDRV should be given?
If an immunoglobulin was given before
in the past,
and the patient presently has a class 3 bite, it does not require a rabies immunoglobulin because that means such a patient has previously taken a post-exposure prophylaxis. He has enough of memory cells in his body. He just needs to take 0 and 3. He does not require an immunoglobulin.
Same question only reworded. If immunoglobulin is required for re-exposure, is given 0, 3, 7 only in previous vaccine.
I'll read it, Gopi. I'll read it, okay?
Yeah, that's better. Okay, ma'am.
I'll read it.
Yeah, fine.
Okay, if a patient has taken 4 doses of IDRV 2 years back, now coming with a category 3 dog bite, should we ask for a documented proof or should we ask for 4 doses of IDRV and immunoglobulin? You should definitely ask for a documented proof because you need to have a document. Otherwise, the patient develops a rabies or the patient has not taken the vaccine completely. We will be in this thing. So documentation is definitely needed. Otherwise, take it as a fresh case and go ahead. If given 0.37 dose of ARV, then discontinue. What is the schedule for re-exposure? Need full vaccination. So here, so I will not confuse you. Standing by the current national guidelines, even if the patient has taken 0.37, he cannot be taken as someone who has completed a pre or post-exposure prophylaxis. So he needs to be taken as a new case itself. WHO guidelines are different, but here you have to go ahead and give the full vaccination because that is what the national guidelines say. If there is a category 2 wound over the face, do we consider it as category 3? No. Category 2 wound is category 2 only. But remember, what is category 2 on the face? Highly unlikely that you're going to get a category 2 on the face. because licking on the mucosa, exposure to the mucosa, aberrations where the blood is seen are all category 3. So category 2 on the face is unlikely, but in case it is a category 2 on the face, it is category 2 only. If the dog is confirmed to have taken we already said, even if the dog has taken the vaccine, it is always preferable to go ahead with the post-exposure prophylaxis. Okay, if a 14-year-old boy coming with RTA and vaccinated till date, the boy can wait for 15 years for the next TT. If the 14-year-old boy had received the 10-year TT at 10 years of age, he does not require a TT. But there is also one, WHO also has one line in the guidelines, that is, if the physician feels like giving an extra dose of TT, it may be given. So if it's a very contaminated wound and you want to give an extra dose, can be given. But routinely, this particular child does not require a TT because it is less than 5 years. Is immunoglobulin required for re-exposure if given 037 only in the vaccination? I said, according to the national guidelines, it is recommended. According to the WHO, it is not recommended. But for legal purposes, we have to stick to the national guidelines itself. So unless you have taken 07 and 28 or 037 and 28, you cannot consider as a completed vaccination schedule according to the national schedule. So day 28 is important according to the national schedule. If immunoglobulin is given in the past, if again class 3 bite, no further immunoglobulin, just go ahead with IDR. I think this question probably we didn't ask. No? Most often patients come with kittens and puppies biting. How should we advise? Kittens and puppies transmit rabies. So you have to do it just like a big dog, because the last rabies death we had was from a puppy bite. Because it was a puppy, they thought it is okay, he will not get the... In fact, the child was asking for vaccine, but the parent refused the vaccine, telling that it's a small puppy, he is not going to have rabies. And the irony was when the child came to us, admitted with features of rabies, at that moment also the child is demanding the rabies vaccine. Such an irony it was. So please don't take puppies and kittens lightly. Small kittens and puppies can also transmit a disease. If a person has taken first and second dose IDRV and missed the next dose, should we reschedule him? Now we said that first and second dose taken, then give no. If you miss the next dose, whenever he comes, take that day as day 7, and then you give the day 28, 3 weeks later. Suppose immunoglobulin was given prior to 2009 and a new category 3 bite comes. Should it be considered as a new bite? No, when you have received the immunoglobulin is not important. If you are previously completed a post-exposure prophylaxis, you don't require immunoglobulin, you only require vaccine. I think we have completed these, right? Any new questions? Okay, the last question. Most of the patients come now asking for it, saying they take every 6 months. What advice to be given? Okay, so this question is applicable for a person who's continuously at high risk. So when we take a pre-exposure prophylaxis, remember we have two aims. One is whether you are trying to protect yourself with unexpected exposures, or are you aiming to protect yourself with expected exposures? What do I mean by that? If you are a person who is involved in, say, catching stray dogs, or you are involved in a laboratory, especially not even catching, a laboratory where you're dealing with rabies virus, that means you may have an exposure and you might not know that you have an exposure. Such a person requires booster initially at 6 months. And after that, he needs to check his titers every 6 months and decide whether a booster is needed or not. If you are not a person working in the anti-rabies, in the rabies laboratory, rather you are a veterinarian working, then what is recommended is after you have taken 0728, it's better to take another dose 1 year later. And 1 year after the last dose, check the titers. And depending on the titers, you can plan whether boosters are needed. The routine boosters every 6 months is definitely not recommended for you and me or any common person. We just need to take the pre-exposure prophylaxis, and on any re-exposures, we need to vaccinate ourselves. No. The question is, If the dog is
Can be.
observable, can we give IDRB and wait for 7 days for immunoglobulin? Absolutely not, because immunoglobulin cannot be given beyond 7 days. So if it is a class 3 wound, give the immunoglobulin as early as possible. You cannot give immunoglobulin after 7 days. If you're giving after 7 days, you're interfering with the vaccine's ability to produce an antibody. You're completely messing up the situation. So please don't do that. Start the immunoglobulin along with vaccine. It may be given up to 7 days, only that we tell.
Dr. Shrija, I think so. That question regarding the earlier one, which you answered every 6 months, no, it's about TT vaccine, I think so. Most of the patients come now asking for
TT for
TT,
6 months.
saying that every 6 months they want. What advice would you like to give?
TT for every 6 months. No, here again I said, when they come for a TT, ensure that they have taken 3+1 dose. So they have already previously taken 3 doses of TT and taken 1 more TT 6 months later. That is total 4 doses has been taken. Tell them for the next 5 years, you're protected. You don't have to come to me for a TT. Okay, 3 doses appropriately placed with the last dose at least 6 months after the previous dose of TT does not require a TT for next 5 years.
I think this is something that everybody has recommended dose 037, and should we discontinue if the dog is okay after 10 days?
I would say take the day 28 vaccine so that it becomes a complete prophylaxis rather than missing on the day 20. Anyway, you've taken 037. So if it is a IM schedule or if it's an ID schedule, take the day 28 so that you have a completed schedule. I would prefer that.
I think so. Regarding the 6-month-old baby bitten by a bandicoot at night with bleeding, should the baby be given rabies vaccine?
Yes, definitely. Because bandicoot means it can transmit rabies, and irrespective of the baby's age, here it will be given.
So that means what about the immunoglobulin?
Yes, immunoglobulin.
Because bleeding is almost 3.
If the bleeding, immunoglobulin will also be given, definitely, because the baby's ability to produce an antibody is limited. So definitely both vaccine and immunoglobulin will be given. Rabies is one thing we don't take a chance upon.
Yes.
Vaccinated dog bites an unimmunized person, yes, we will take vaccine. Definitely. I think I covered that. We cannot guarantee the whole criteria has been fulfilled. So that is why vaccination is recommended. So I think that finishes. I hope if someone wants to raise hand or ask, can ask. Otherwise, I think I've completed. I think there's one question. Guideline says that first 3 doses should be completed in 10 days. Otherwise, we should restart. It is not exactly that wordings. I agree with this thing that you have said, because in the national guidelines, they say that the first 3 doses needs to be completed within 10 days. If not, extra doses should be considered. There is a term like that in the national guidelines. But the WHO categorically states that you don't have to restart. You just need to continue from where stopped. So you may decide to give an extra dose. That is okay. Especially if it is a confirmed case of rabies, you may think of giving an extra dose.
One more question is, dog bite presented as a delayed presentation healed wound. Where should the immunoglobulin be?
Okay, means like the first scenario, patient has 2 months back, has a bite and then coming. Again, you will give the immunoglobulin at the site of the bite. Even if that wound is healed, you would be inoculating the immunoglobulin at the site. And similarly, if you have a very small wound and the whole immunoglobulin cannot be inoculated at the site of the injury, then the rest of the immunoglobulin should be given as close to the bite as possible. In fact, WHO no more recommends the rest of the immunoglobulin to be given. The national guidelines is the one that recommends, and the rest should be given as close to the site of bite as possible. If someone is bitten in
childhood many years ago and not vaccinated against rabies, what?
We've said about a long incubation period of 6 years. It's extremely rare. Most, if you look at the Kerala data of rabies vaccine failure, all of them manifested by 1 month. Most of the death happens exactly between 1 month to 6 weeks of the bite. So don't be scared if you had a bite in the childhood. That dog must be alive now, must have died, but not due to rabies. So not needed, but remember that concept that it can, in rare situation, be a long incubation period. So go ahead and take the vaccine.
Madam, how long should we advise if somebody comes like that such a situation, like 3 years back?
Even then, take this as an opportunity to give an anti-rabies vaccine. If not without the immunoglobulin, let them take the ARV. Definitely. If a child develops anaphylaxis after rabies immunoglobulin, does the child need only adrenaline or both IV hydrocortisone and adrenaline? The first thing is definitely adrenaline, but we'll give the hydrocortisone so that it does not develop a late phase of anaphylaxis. I think the question was asked very, very thoughtfully, thinking that being a vaccine, will it suppress the immune response? But then if the patient has an anaphylaxis, that is also life-threatening. So in order to prevent the late phase, we will give hydrocort also. Which is better, IM and IV? Both are good. I will not put one over the other. Both are good.
And I think so, which you are most comfortable with,
Yeah,
ideally.
Yes.
There is no more questions. Can we wind up?
So we'll wind up.
Yes, I think so. We can wind up. Okay, I think so, Dr. Johnny.
Thank you
Since
so
Dr.
much.
Gobi Mohan is
No, I think someone has asked
Yeah,
this question.
yeah.
I'll just answer you that.
sure.
Just one thing, I think she's asked that question twice. So I would like to say that if the 0 dose was invalid, IDRV dose, and the other 3 doses were correct, could the immunization be effective? Yes, Nivedita, it could be effective because ideally all the doses should be good. But when you're giving 3 more doses, it would have produced a good antibody response by now. Okay. Where do we check titers in Kerala? In here we have the rabies laboratory is there in Payad. In Payad, there they do the titers. Pepatti Vishebadha Gaveshna Kendram. There they do it. Okay, if 3 plus 1 dose of TT were inappropriately placed, what should be done? Even if it is inappropriately placed, you take that person. If he has taken the last dose of TT at least 6 months after the 3rd dose, he is protected for the next 5 years. Between the doses, at least 1 month interval should be there. He is protected for 5 years. I think we'll wind up.
Fine.
Thank you.
Thank you, Dr. Sija, madam, for that extensive and crisp talk covering all aspects of tetanus and rabies. I also thank Dr. Shimi and Dr. Johnny and all the participants here. We had around 130 participants, 30 in YouTube and 100 here in the first time we are crossing a century. Thanks to Sija, madam. Thank you, everyone, once again. Good night.
Thank you so much. Good night. Thank you so much.
Thank you, ma'am. Good night.